So Dr. Van Tassel, if you could go first, that'd be great.
Hi, my name is Ben Van Tassel. I am a pharmacist and I'm a professor here at the VCU School of Pharmacy. Most of my work focuses on cardiovascular diseases, but over the last couple of years, we've reoriented some of the work we do to include clinical trials for patients with COVID-19, testing out some of the newer treatments and trying to make those options available to folks within the hospital.
Great, thank you. Dr. Gravit, would you introduce yourself for us next, please?
Hi, my name is Dr. Gravit, and I'm an associate professor here at the School of Pharmacy. And a major bulk of my teaching is in infectious disease. I'm also an internal medicine clinical pharmacist where I am taking care of COVID patients on a daily basis. So it's definitely something that I'm seeing in and out of the classroom.
Great. Dr. Meyers, would you introduce yourself for us, please?
My name is Matt Meyers, and I am an inpatient operation manager across the street at VCU Health. I actually am an alum of VCU School of Pharmacy. And basically, if you're in the hospital and you need any medications, it comes from our team. And then since December, I have been doing a lot with COVID vaccines, with the preparation and the distribution as we vaccinated our team, and then we continue to vaccinate patients.
Wonderful. Thank you for being here with us today. And Dr. Roman, would you close us out for introductions, please?
Sure. Hi, everyone. My name is Yusuf Roman. I'm an assistant professor at the School of Pharmacy at VCU. My research is focused on the understanding the genetics of cardiometabolic diseases, also understanding what are the sources of variability in response to treatment, specifically the genetic causes of that. Happy to be with you.
Wonderful. Thank you all for being here. And I realized I forgot to introduce myself, so I'll just do that real quickly. I'm Madeline Wagner. I am the program support assistant for the Center for Pharmacy Practice Innovation, which is who's bringing you this Lunch and Learn today. So those of you watching, thank you for being here with us. And to panelists, thank you also for joining us again, some of you, since our last chat about the COVID vaccine. So I'm just going to jump right in to our questions. Feel free, if you're watching on YouTube, to post any questions you have later, and we'll see if we can get to them. But for now, we're going to go with what we've prepared ahead of time. So Dr. Gravit, let's start with you. What are people talking about when they mention COVID-19 variants? I know we've heard names like Alpha and Delta. Can you give us a little information about that?
Sure. So COVID-19 is a virus, and just like any other virus, like your flu viruses and a lot of other viruses, the virus's job is not only to infect people, but to also find a way to live no matter what. And just like with any other kind of evolution, it tries to make itself a little bit stealthier so that way it avoids being killed. And so that's really where these variants are coming in, are modifications that the virus is making to itself to make sure that it can stay alive. So it's just trying to be sneaky and get around the normal ways that your body is trying to attack it and try to get rid of it in general. Now, the current variants that we're talking about, as they're trying to look at each one of these, they try to group similar areas of variants together. And so we have Alpha, Delta, Gamma, and then I feel like I'm forgetting one, Beta as well. So I should have gone in order. So the one that is of most concern right now is the Delta variant. And a Delta variant currently is in about 99% of the viruses that we're actually culturing from individuals. So that's really the main variant that is circulating in the environment currently.
Gotcha, thank you. Does anyone else have anything they want to add about variants before we move on? All right, so why you said Delta is most prevalent right now. Dr. Van Tassel, I guess, do we need to be concerned about this particular variant? How is it different? Very general terms, how is it different? And why should we be concerned about that, I guess?
So I think the first answer is yes, we should be concerned about it. And one of the biggest differences between the Delta variant versus the original variants that we were seeing is that this one does seem to be much more easily spread. So if you had a similar exposure to somebody who is infected a year ago versus somebody who is infected right now, you actually have a much higher chance of catching the virus now with the Delta variant being out than you might have a year ago. So I know that there's a natural tendency to think, oh, we've already been through this and we can kind of let our guard down a little bit. But the reality is that the variant that's out right now is more infectious. So as a first line of concern, that's what we're facing right now. The other thing to add into the conversation is that this variant might also be a little bit more pathologic in terms of causing patients to become even more sick should they catch it. So for a couple of reasons, this variant might actually be more problematic than what we've seen in the past. And then I would say one more thing about why we should be concerned about it is that even though we do have better treatments now, even though we do have more things that we can offer patients should you become sick, there are still a lot of unknown consequences in terms of, what is going to happen to folks that are, 6 months or 12 months removed from their original COVID-19 infection. We're learning that there may even be some long-term consequences to having this virus that are that might be problematic going forward. So I think for a variety of reasons, we should, there is reason to be concerned. There's still some problems from this virus.
Sure. So I guess one of the big questions that comes to my mind, at least after hearing that, is the vaccine that's been developed for a little while now. Is it effective against the Delta variant and other variants? Dr. Gravit, if you could take that for us. That'd be great.
Yeah, sure. I think that's the big question that's on everybody's mind. If I went and got the vaccine, shouldn't I be protected? And the answer is overall, you are. So one thing I just want to preface all of this is that if you go back and you look at the studies with all three of the vaccines, the main endpoint for each one of those is preventions of serious infections and death. And I can go ahead and tell you that is happening with this particular vaccine. And it's not 100% even for that, but for the most part, that is actually happening. And so that's actually really great to see. Does that mean that you can't get infected? No, that doesn't mean that. So I do think it's important to kind of delineate what we were looking at first and what is our goal point. Because if it's our goal point, do you get infected or not? That's going to be very different. Is do you have serious infection or death? So that's a big thing. So if you look at the Moderna studies, there's actually one that's out there, particularly in Canada, and they looked at with the Moderna vaccine that with this, that one dose of the vaccine was at least 96% still effective in preventing severe disease. And that was even just with one dose. And even with the Delta variant, the vaccine's outcomes was still 96% effective. So as far as going back to preventing serious illness and also death. So Moderna is really proving out to be very good as far as with the Delta variant. If we look at some of the other ones, so Pfizer in particular, so it depends on which of the studies. So there's been a couple of different ones that have been published. There's one out of UK, one out of Canada, one out of Scotland, and data also in Israel. Now, I know that sounds like really confusing, that all these different places. And I will tell you, though, they are all showing something slightly different. So the UK data suggests that with the Pfizer vaccine, you're 88% effective in preventing severe disease and death. So very good. And then also too, 80% in preventing infection at all. So do you get infected or not? It does seem to be doing a pretty good job with that. However, if we look at the Scotland and the Canada data, a little bit different. So 87% effective in Canada, 79% effective in Scotland, and in Israel was actually the lowest and showing about 64% efficacy. So that's just one thing to note is we are noticing that there does seem to be a little bit of a difference when they're looking at the countries individually. What I would like to see at some point is if we can know globally really what we're looking at as far as effectiveness. But what this does tell us is, again, Pfizer and Moderna are still doing a good job of keeping people out of the hospital and keeping them from dying. Now, what about J&J? So the one data that we have with J&J is that it's 85% effective in preventing severe disease, even with the Delta variant. So that seems to be holding up well as well. So we do know that the J&J didn't have quite as robust of data to begin with compared to the two mRNA vaccines. So I think that there may be some room for improvement there. There was an unpublished, well, non-peer-reviewed study that was out that has looked at the J&J vaccine and the effectiveness and is suggesting it might be closer to 67 to 70%. So I think if we're looking at it, which one's doing best, like who's winning, okay? I would say probably Moderna's winning, Pfizer next, and probably J&J, probably around pretty close to Pfizer though.
Yeah, that's really helpful. Thanks for breaking that down for us, Dr. Gravit. Dr. Meyers, kind of building on that, say I'm someone who's hesitant to get the vaccine. If I'm looking at this data and, you know, these percentages, what, why would you say like people who, health professionals are still advocating for people to get vaccinated? You know, that some of those percentages aren't as high maybe as we saw at first, or maybe I'm weighing my risks and I think I can avoid it. What would you say to that, I guess?
Yeah, no, I think Dr. Gravit teed this up perfectly with the percentages and the endpoints. You know, people, I think there's a misconception that you get the vaccine, you're not going to get COVID. It's not that you're not going to get COVID. It's that you're not going to die, hopefully, and that you're not going to get hospitalized. And that's really what we see here. And she can probably speak to that as well, too, that the majority, and I don't have the percentage, but I mean, it is the majority, you know, significant, I would say in the 90s, 99% of our patients that are in our ICUs right now are not vaccinated. So, you know, I liken this somewhat to the flu vaccines. You know, every year we make the flu vaccine and we put the strains that we see across the world in there. And, you know, then sometimes something else pops up so that maybe you still get the flu, even though you've had the flu vaccine. But if you had the vaccine, you don't get typically as sick as if you're unvaccinated. So this is, again, same idea, different virus, same principle. So I think that's really a big thing. And I mean, just the longer we go, the more and more the data is showing that if you get the vaccine, yes, you can get COVID. Yes, you may not feel great, but you're not going to get hospitalized. You're not going to be in the ICU. You're not going to be on a ventilator, and you're not going to die. I mean, for the majority of those patients. So I think that's really the key takeaway. You know, and that's what we really press to anyone, the patients that are here that are kind of on the fence. You know, our employees, as we've moved to now mandatory vaccinations, there's a lot of employees that really aren't comfortable. They aren't sure about the data, but you know, when you show them this data, it's pretty strong at this point. You know, at least short term, this is what it's doing, and it's doing what they set out to do initially when they said this is what we're going to create. So
Sure. Kind of going off that, Dr. Van Tassel, we've kind of started to answer this, but why are we still wearing masks even if we're vaccinated? I think a lot of people might be asking that.
I think that's a good question. Going back to, you know, the data that have been presented here by the other speakers on the panel, it's important to recognize that yes, these vaccines reduce your risk, right? And that's how they're winning. That's the effect of the vaccine that we're hoping to accomplish. They reduce your risk of being hospitalized or worse, but they're not 100% able to reduce that risk. They can reduce it by a percentage, but there's always going to be a chance that you're still going to be susceptible to that, and there's always going to be a chance that you could still get really sick. So we try to think of this as a layered approach where yes, we want widespread vaccination to minimize your risk of catching this, but while these variants are still out in the community and while there's still high transmission happening, it makes sense to do the extra little things that we can do to reduce our risk of catching this virus, so we don't have to rely on the vaccine to save us from being hospitalized. So masking is still something that we recommend. It's a nice, simple thing that you can do to lower your risk. I wish that we could wave a magic wand and just, you know, all of the COVID would just disappear and we wouldn't have to be dealing with it. But that's not our world right now. You know, right now there are still real risks out there, and masking up is a way to lower that risk. And I think it's similar to a lot of people have talked about, you know, having the different systems that we use in a car to prevent an accident, right? There are, there are seatbelts that we use, there are brake systems that we use, there's reinforcing in the cars that we use, and none of those on their own is going to prevent all of the risk of getting into a car accident. But that doesn't mean that we should disregard each of them individually. Masking up is one of those ways that you can reduce your risk. And yeah, it's a little uncomfortable. And yeah, sometimes you're going to forget. But at the end of the day, it's still a nice, simple thing that you can do to help further reduce your risk of catching this virus.
Yeah, that's a helpful visual, the layers of protection in a car. I like that. I guess my next question then would be, Dr. Gravit, if people are getting vaccinated, and I've also heard numbers about like breakthrough infections and how low of an instance that is happening. But if we're increasing vaccinations, why then are COVID infections also increasing?
So part of that has to do with what Dr. Van Tassel said, is that this new variant is highly contagious. It's nearly 3 times as contagious as what we saw initially. Okay, so one person on average can infect up to 5 to 6 other individuals, which is crazy if you think about that. So the question is, where does the virus have to go hide? And that goes with how many available vectors that is open and ready for business for that virus to take root and start replicating and start inviting friends and then share it with others, up to 6 other people. So if you think about that and you have an area that has low vaccination rates, that means you have more vectors, more people that virus can start replicating. So what we started noticing, especially with the start of the Delta variant, is we started seeing this uprise, specifically in areas that have had lower vaccination rates. So we have 2 issues at play. So we have lower vaccination rates in certain areas, because we know not all places are created equally. And then we have something that's way more contagious in general. So I think it's just kind of leading to, an ability to infect more people. So I think the other thing to put into play here is, after we saw the first surge, well, I mean, this is like what? I think we're on 3rd or 4th surge. It's hard to remember now. I kind of stopped counting surges. But especially during the winter, and we started coming out of the winter, we started all feeling really comfy. And then they were like, well, guess what? If you're vaccinated, you can take off all of this. So then we started doing more things with more people. So then it's not kind of surprising if we're going to be with more people and around people, especially in enclosed places without masking during that time, that eventually you're going to see an uptick in those numbers. I did want to make one comment based on what Dr. Meyers had said, in that looking at the number of people I have seen with COVID and looking at breakthrough infections, in general, I would say 98 to 99% of the patients I have that are coming in COVID positive are not vaccinated, and they are sick and they are young, and it is scary. I'm telling you, there are people who are 20, 30, 40 years old who are extremely sick, and it's just and they have no other pre-existing conditions. Everybody wants to ask me, well, those people, they were already not well to begin with, right? No, these people were fine. They were just like we are right now, but they didn't get vaccinated, and that's the only difference. But what about those people that have breakthrough infections? What I can tell you is that by and large, almost 100% of the people I have seen have been people with predisposition to getting infections. So patients with, for example, COPD, who are at high risk for developing respiratory infections to begin with. Transplant patients. I've had a number of transplant patients that have been not able to get their booster yet, who then got the variant. So it's really patients with more compromised immune systems baseline that we're seeing a lot of these breakthrough infections who end up hospitalized or needing ventilators. So even those people, it's really probably preventing them from being much sicker than what they would have been otherwise. So
that's good to know. And that's helpful. That actually leads into our next question about booster shots. Dr. Roman, if you could take this one at first, that would be great. So we've heard kind of a few different things, but generally the CDC has recommended booster shots for certain populations. Who would you say should be considering getting a booster shot right now?
Yeah. Thank you, Madeline. So definitely, I think Dr. Gravit already touched on that already. The reality is certain people who received whether the J&J or Pfizer, Moderna, they not necessarily developed the desired immunity that we would like to see as an individual or basically of someone else. And unfortunately, that was attributed to the fact that certain people have predispositions, specifically compromised immune system that does not give them the ability to produce the antibodies necessary to protect them from having the infection. So what are those people that could develop this kind of compromised response? Generally, people who have already autoimmune disease, so people who have compromised immune system. People who have existing condition that makes them almost immunosuppressed. So for example, people with transplant, they need to be chronically immunosuppressed. That puts them at a lower response rate to the vaccine, and also puts them at a higher risk for developing basically the COVID infection or COVID complication. So at this point, what we know about booster is that it's recommended for those who have existing immunocompromised condition or having the condition that put them at a lower risk for let me reword this, put them at an undesired response to the vaccine, so they don't develop the right amount of antibodies to the vaccine.
Right, gotcha. That makes sense. So I know there's booster shots for Pfizer and Moderna, but the J&J shot is still under development. Is that correct?
Yeah. So, well, actually, let me take a step back a little bit. So the CDC at this point recommended the booster shot for people who have already established immunocompromised condition. In terms of having the sort of the umbrella of having everybody taking a booster shot, that's still being investigated. Actually, we, at this point, while we're having our panel, the FDA actually also having a panel right now to discuss whether the booster shot should be basically given to everybody. So we're doing almost this simultaneously. J&J probably will, but at this point, there's no clear data to guide whether it should be a booster shot for J&J at this point. So the data is being discussed and being evaluated by the FDA right now.
That's great. That's good to know. I actually saw that this morning. I was hoping one of y'all would mention it. I also saw recently the New York Times released something, kind of a two-sided argument of whether you should mix vaccines. Can anyone comment on that? Like mixing vaccines for booster shots, like if you got the Johnson & Johnson first and then you don't want to wait for that booster to become available. Obviously, I think that's a conversation each individual should have with their doctor, but is there anything any of y'all can comment on that about?
I'll actually go ahead and obviously I'm curious to see what my colleagues think. So to be honest, I think it's probably, there's really not much data yet to figure that out in the first place. Second is probably it's recommended to stick with what you started. That's probably the preferred approach. But obviously sometimes we have to make decisions and we have to, kind of change things up a bit. But clearly, if you take the J&J, probably J&J obviously has a vaccine. It's not the same as the Moderna and Pfizer. So they're definitely two different entities. So clearly, they may not be necessarily interchangeable in some ways. Maybe Moderna and Pfizer, there's a little bit of overlap. So there might be a room in there. But however, I mean, obviously, I don't know the data fully to be able to make that recommendation, but I'm curious to hear from my colleagues on the panel.
I can jump in and maybe add another layer to that. I think that there are scenarios where just in terms of what's available at the time, if you get to the situation where only one vaccine is available and you're due for that second shot or you're due for that booster, it makes sense to go ahead and get the one that is available. I think in almost any scenario, one of the vaccines is better than no vaccine. So we don't actively discourage people from switching if that's really the only option they have to continue or to complete their vaccination series. In terms of, can you switch when you're getting that booster shot? I think it's important, like Dr. Roman is saying, is to recognize when we've reached the limitations of where the data take us. Frequently, we run into these situations in clinical practice all the time where we don't quite have enough information to guide us. So if we're going to cross that line and step past where the data have taken us, we're starting to guess, we're starting to extrapolate. And I think that that's generally going to be discouraged for most folks. The other reason that I think it makes sense to stick with the same vaccine that you've been getting is that throughout this pandemic, we've really been confronted with a situation for which the answers weren't immediately apparent. You know, we're used to modern medicine being able to have really strong evidence-based answers before we go and just start trying things. But what we've learned during the pandemic is that even when we get to those areas where we may not have all the answers, let's make sure that what we're doing is going to generate reliable information that other people might be able to use going forward. So it makes sense from that perspective then to say, if you started on the Pfizer vaccine, let's finish on the Pfizer vaccine. And if you're going to get that booster, let's try to stick with that same vaccine so we can learn from that experience and add to our collective wisdom. If people are randomly switching from one to the other, it makes it harder to understand it makes it harder to use that information to inform future decisions. So trying to be systematic about it in this case does actually make a little more sense.
The only other thing I was going to add to that is that there would be certain circumstances, and I don't know if you can really call it a booster, where maybe one person had an mRNA shot and then they had a reaction to that shot. The recommendation is for them to not get that second dose. However, I have seen recommendations that they go ahead and get the J&J after that. So I will say that would probably be the one caveat where you may swap it out, because we do know with one dose is not as effective. I didn't talk about this in the previous data, but some of that data with Delta variant specifically looked at what happens if I just get one dose, okay? And it shows that Moderna did pretty good, actually, even after one dose. However, Pfizer was very low. Pfizer did not do well with just getting one dose of Pfizer. So I would definitely think that that would be another reason to think about mixing and matching is, let's say you got one of those, you had a reaction, then I would recommend maybe go ahead and get that J&J. And we have been doing that a little bit more now as we've had all three available. But I do think it's going to be interesting, because even myself, I've postulated, well, maybe if they're having breakthrough infections with one, then we definitely need to look at that to see what we need to do. But, you know, here's the other caveat. We don't know what's around the corner, right? So that's how we're dealing with the variants right now. What do we do once that variant changes? And it's going to eventually. So just something to think about.
Yeah, that's helpful. That's helpful to keep in mind, I think, as we're trying to make the most informed decision possible, just remembering that the data only takes us so far right now because of how new everything is. Dr. Meyers, coming to you, you mentioned this a little bit earlier. Flu season officially kicked off this month in September. So folks are likely thinking about getting their flu vaccine soon. Do you know, can you talk a little bit about kind of the flu vaccine and the COVID vaccine? Does anyone need to be concerned about any interactions there? Is there preference for one over another? Can you speak to that a little for us?
Yeah, I can speak to that. So I would say initially when the COVID vaccine came out, one of the questions we asked was if you had a vaccine within the last 2 weeks, or are you planning on one? Because we didn't know enough about the COVID vaccine to know would it interfere with anything. I'll say now that stance has totally changed. And it is, you know, they're even, I think Moderna announced earlier this week or late last week, they're actually trialing a combo flu and COVID vaccine. So if that doesn't tell you that the stance has changed, I don't know what will. So I think it's important, again, to get both vaccines for different reasons, you know, and if it's convenient to do them at the same time, then do that, you know, but you don't need to space it out to worry about the effectiveness of either vaccine or being hurt by taking them at the same time. You might not feel as well if you get them both on the same day, potentially with side effects. That would be maybe the only thing I'm worried about, but I wouldn't, from what we're seeing, the effectiveness is not, you know, inhibited by getting them within that, you know, same time frame.
That's good to know. That's neat that they're making a combo shot for those who don't enjoy shots, perhaps like myself. I'm also hearing quite a bit about unknown long-term effects. A few of y'all have mentioned that as well. Long-term effects from the vaccine, as well as from COVID. But I think a lot of, from what I've heard from my my personal friends and family, a lot of vaccine hesitancy is tied into unknown long-term effects about the vaccine. Dr. Roman, could you talk a little bit about, I guess, what we do know that maybe we didn't right when the vaccine first came out as far as long-term effects?
Yeah, no, that's definitely a valid question. I think it's a very important question to address and really to elaborate on, because it is definitely one of those factors that is really contributing to vaccine hesitancy and obviously why some people are not being vaccinated. One thing we have to keep in mind is what we know about the vaccine is about how much we have data so far. This process hasn't been there for that long. I mean, we are in about a year and a half data worth of data, assuming we take all the preclinical data into account. So from a long-term standpoint, it's probably that's how much we know so far. And what we know so far is those vaccine, I mean, amazingly safe, amazingly effective compared to what we have seen from previous studies and previous trials. Those two vaccines, especially the mRNA vaccine, have really been shown to be one of the safest vaccine we've ever had so far. Besides, obviously, the fact that you can develop, some pain and some fatigue and tiredness as a result of the vaccine, we have no major side effect that has been reported to make us be concerned about the long-term effect of these particular vaccines. So far, to summarize that, is really, I mean, the long-term data, first of all, is that's as long as we know so far, there's no concern about long-term effect. And I think so far these data support that those vaccines are safe, effective, and you should be vaccinated unless you really have a very strong reason for not to be vaccinated.
That's helpful. Thank you. Dr. Van Tassel, I see you put something in the chat. Do you mind elaborating on that for us?
Oh, sure. I was just, as Dr. Roman was talking, in my mind, it really boils down to, we're thinking about the uncertain consequences of the vaccine. I think it really boils down to potentially the fear of the unknown versus the very well-known consequences of COVID. And so from that perspective, to me, it's a pretty one-sided consideration in that we know very well what this virus can do to people, and it's not pleasant, versus these vaccines that I guess, yes, theoretically, there could be something that we've missed in the millions and millions of people that have been vaccinated that isn't going to show up until years down the line. But I think it really takes a lot of mental gymnastics or, really intentional worrying to get to the point where that really outweighs the known risks of COVID. So if you're weighing things in the balance, it really tips favorably towards the benefits of the vaccine.
Sure. Dr. Gravit, another question that I've heard asked by a few people is, will, particularly women my age who are, maybe considering having children someday, will the vaccine, is there any potential for it to affect my ability to have children, for it to affect someone's menstrual cycle, anything like that?
So I'm going to put it into two different groups. Okay. So I think, does it affect fertility is a slightly different question than will it change my menstrual cycle? And I know that in some ways it's hard to not tie those two things together, but I'll tell you in a minute why I think those are two separate things. So the first question is, does it affect fertility? And the answer so far has been no. So if we look at the animal models as well as the human studies that were done, even within the clinical trials, both for Moderna and Pfizer, they had a number of females. And I think the actual number, 4,800 people that enrolled in those trials ended up getting pregnant during those trials, and they did fine. So I think that should give us a little bit of, pause that, okay, people are getting pregnant even though they have gotten these vaccines. So that is the good news. Even there's a couple of institutions that got together and published some data that showed with US healthcare systems, because US healthcare systems were some of the first that had access to a lot of the vaccines, that more than 1,000 people who completed the COVID vaccination then later reported getting pregnant. So, so that's just something else to kind of think about. Again, people are still getting pregnant on the COVID vaccine. Good news. So if we look at specifically what is the effect on fertility for males, and it looks like, again, that there does not seem to be any issue with males as well. I will note, however, there are some studies that suggest males that are infected with COVID has been shown, when they've done some studies, to have decreased sperm production around the time of having COVID. So it does seem that it may affect males quite a bit from having COVID. So that's just something to think about, that what are the fertility risks from getting the infection in of itself? Now, that's also been questioned in females as well, but females are still getting pregnant even though they've had COVID. So that's showing that it still is happening as well. But there is actual data out there about decreased sperm production. And then there's another thing about reports of men having testicular and scrotal pain, even post having COVID, for up to a month or more. So I don't know. I'm not a guy, but I got a feeling if you told that to a lot of men, they would not be like, sign me up for getting COVID. That sounds wonderful. So that's one thing to kind of put in that. So can you safely get pregnant after getting these vaccines? It seems like the answer is yes. And it is recommended, and it's recommended for if you're thinking about getting pregnant, as well as if you are pregnant. If you look at all of the governing bodies around OB, they pretty much all are in agreement that you need to get the vaccine even if you're pregnant. And that the bonus is you can actually produce antibodies to help protect your infant even before they're able to get any kind of vaccinations. So that's an added bonus as well. Now let's take the next part, which is, will it affect my menstrual cycle? Okay, so why are the two things not linked? Okay, so I think that just because someone's having a regular menstrual cycle does not necessarily mean that they're not fertile, right? Because they're sometimes linked and sometimes they're not. So I think you can't always say that one thing affects the other. What are some known things that can affect people's menstrual cycle? Stress, actually. Guess what times we're in? Some stressful times. I'm sure actually if you probably tracked individuals' menstrual cycles, which I haven't found a study that particularly did this during COVID, whether or not you were vaccinated or not, I think that you would probably find that everybody has had some effect, that it could be different. There's also a known thing with any kind of vaccine or anything that stresses out the body, that it actually can change your menstrual cycle. That is something that is known about vaccines, that you may notice a slight change. Now, what are those changes that I'm talking about? This is not long-term changes, but individuals after vaccines, it has been noted that they may have a heavier cycle, or that they may, go longer than normal in between cycles. But it really should correct itself within a couple of cycles. And that's really what has been noted. Now, the problem, I think, is when they did the initial trials, this is not an outcome that they were specifically looking at. They were looking at fertility, yes, but they weren't looking at, does it change your menstrual cycle? So they didn't ask the question. You don't know what's going on if you don't know that that's a question you need to ask. And so there's actually several trials that are ongoing now where they're going back and looking at what are the changes in menstrual cycles for those individuals, just so everyone can be better informed, but also so people can rest assured that it's not necessarily causing long-term effects for their fertility. And I understand that people are nervous about that, but I really think we should, definitely be promoting the vaccine, and it has been found to be safe.
Yeah, thank you for breaking that down. That's a great point about kind of separating those two things, fertility and your menstrual cycle, because they are different. I think we just have one more question, and then I'd love to hear any last thoughts from each of you. Dr. Van Tassel, we'll come to you for this one. If the vaccine is safe for kids, right now it's only available for those 12 and up. Do we know why it isn't available for any kids younger than that yet, or when it could be available for younger children?
It's a great question. It's an important question, and it hits pretty close to home in my family. We have an 11-year-old who, his older siblings are all vaccinated. His parents are vaccinated, but he wants to be vaccinated, and so he feels a little nervous sometimes that, he's the one that's at the highest risk of getting infected. And so it does, hit close to home, and I would love to be able to offer that to him. But I think it's important to think through, the process that we're going with these vaccines. So first of all, we just don't know. We don't have the answers to that question yet. And as we tell our students all the time, the most important answer that you need to get comfortable with is, I don't know. When the data haven't really answered something for you, and you can't really quantify the risks versus the benefits of doing something, you need to get comfortable with that waiting process. Now, a year or a year and a half ago, when we really had very little that we could offer folks that were getting sick with COVID, the pressure to come up with the vaccine, the pressure to come up with something, some kind of olive branch or some option that we could offer folks just to help reduce the risk was tremendous. The situation's changed a little bit now. We do have treatments that we can offer people. We do know how to do a better job at taking care of folks once they're sick. So with the question in terms of vaccine for kids, we want to have a good answer. We don't want to rush this. We want to make sure that we're not guessing and just making something available to kids. So it's just going to take a little bit more time. Fortunately, it does seem that kids in general seem to be a little bit more resilient to the major adverse consequences of COVID. So, they do have that working in their favor. And then last but not least, from a drug development standpoint, remember that we kind of consider kids in a special status when it comes to drug development. We try to be a little bit more cautious. We try to be a little bit more thoughtful in terms of how we do research with kids. And until that research is done well enough, we're not going to make the vaccine widely available to the kids that are out there. Even if it's, the 11-year-old in my own household, sometimes we just have to wait and see where the data take us.
Sure, that makes sense. I guess, does anyone have any final thoughts either on vaccines for children or booster shots? Any questions you all have been asked that you think would be valuable for our audience to hear today, the answers to?
So Madeline, I want to echo Dr. Tassel here, the comment he made about children, and I think he's hit on. One thing to keep in mind that kids are not little adults, where we cannot treat them that way. It's not like we give 1 milligram for an adult and we give a half a milligram to children. It doesn't work that way. Kids or generally children or young children, they're different. Their body is different. The way they react is different. So we cannot just extrapolate information based on adult data and try to make it work for children. That's not drug development works, and that's not how it works. So we have to be guided by data, and we have to be guided by evidence in order to make a decision whether an 8-year-old should get the same dose as 12 or 60 years of age. I think that's important to keep that in mind from a public health standpoint, because obviously we don't want to expose our young children to unnecessary harm, especially in the absence of data. So I just want to highlight that.
Yeah, that's a great reminder. Thank you.
And just one other thing I was going to throw out there that people have to keep in mind is I think there's this perception that they started studying everybody all at the same time when they started enrolling patients in these particular trials, and that was not the case. So they didn't even start the trials in children until March or April. And so because there is a delay, there's going to be a delay in getting results. So I think that that's just something to keep in mind, because I've had a lot of people say, well, they've been doing those trials for so long. What have they been doing? And I'm like, well, they didn't start enrolling kids till a lot later. They made sure it was safe in adults first. And the reason why they did that is kind of what Dr. Van Tassel was talking about. We were looking at the people that were dying and the people at the highest risk and making sure that we covered them first. Kids have not been as high of risk. I'm not saying zero risk, but as compared to other adults. So that's just something to keep in mind.
Sure, that makes sense. Thank you for sharing that. I didn't realize it wasn't until March or April they were enrolled in those trials. Wow. Well, great. So those are all my questions. If anyone has any last thoughts they want to add, I would love to hear them. But thank you all for joining us today for this panel. I feel like this will be really good information for for our audience?
Just one parting thought, I would say, if you're on the fence and you haven't gotten vaccinated yet, don't feel like you're being pushed one way or another. But if you have questions, please ask the questions. That's what I want people to do. I've talked to so many people about, I want people to feel like they're making an informed decision. But I think once I inform you, I do hope that you get vaccinated. And I really just think that it's important to think about the things that we can do to help others. So, and that is one way that you can help others, but you're also helping yourself. It breaks my heart when I see these people who are coming in here that are so sick, and there's limited things that we can do for them, unfortunately, at this point. So I think that if you have the ability to get vaccinated and you haven't, make sure you ask those questions and try to go ahead and get vaccinated.